Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
Okay, our first question for you today, Dr. Mingle, is from John. And John asks, we are an ACO preparing to convert to CQM quality submissions. What are the cost drivers to consider as we look at eCQMs versus MIPS CQMs and Medicare CQM options?
Great question, John. No matter how you generate your data, manual, electronic, QDC codes, secondary data sources, or a mix, submission through a qualified registry is likely to be more affordable, scalable, and sustainable than EHR-generated eCQM submissions. If you go the eCQM route, your submission has to be entirely electronic, entirely hands-free, entirely certified. Your HIT vendor will need to receive data from all of your participating practices, deduplicate, aggregate, and submit your data to Medicare or provide you with a file you can submit. Every step of the process, from documentation of care through data exchange to a common repository to measurement and analytics, has to be both electronic and certified. Any break in that chain threatens the acceptability of the data. The process is threatened if a previously certified step falls out of certification or if one or more of your participants changes or upgrades their EHR. I think the main cost driver in this sense is updating that certified chain and the automatic exchange of data, and often involves implementation of an enterprise master patient index, which can be quite expensive to both install and to maintain. For either MIPS CQMs or the proposed for 2024 Medicare CQMs, you will utilize a qualified registry. A qualified registry like Mingle can submit your eCQMs if you have them. Or if your data is already deduplicated and aggregated, we can accept and submit for you a QRDA3 file. QRDA3 files are the aggregate form of eCQM submissions. They contain no patient identifiers. All of the deduplication and all the aggregation has to occur prior to formation of that QRDA3 file. If your data is not already deduplicated and aggregated, you will want to use QRDA1 files if you have them. QRDA1 files are eCQM compliant files that include patient identifiers. And qualified registries such as Mingle can use those QRDA1 files to contribute to and build your final submission. Using QRDA1 files, Mingle can combine your QRDA1 data with other data types from others of your client practices or even from your system to build a deduplicated and aggregated submission for all of your ACO participants. We can use eCQM compliant files from any and all of your ACO participants, but we have the advantage of, first, any step in your process that falls out of certification will not threaten the acceptability of your submission. Simply, nothing has to be certified to be included in a qualified submission. It just has to be correct. We can use any accurate data from any of your partners to build the qualifying submission. It can be flat files from your EHR database, manual abstracted data, data generated by your EHR's automated reporting system, QDC codes generated in your billing system, and others. If you will need to manually abstract data to meet your data completeness requirements, you'll find an advantage with Medicare CQMs, needing only Medicare patients, not all patients, all payers for the typical MIPS CQM submission. You'll have to abstract far fewer charts, a big savings in effort. A further advantage of that selection between a MIPS CQM and a Medicare CQM, if you're using a capable qualified registry like Mingle, you can make the selection of Medicare CQM or MIPS CQM anytime in the process. You can change your mind right up until the end of Medicare's annual submission window. You can even submit both to get both the advantages of, in the final year of eCQM possibilities, that is 2024. Medicare is still offering an incentive in the quality standard if you use MIPS CQMs. Now, Medicare CQMs won't earn that, but you can submit both, earning the incentive, that quality standard incentive with your MIPS CQMs, and perhaps getting a better score with your Medicare CQMs, which will drive your reporting. Thanks, John. Great question.
Yeah, thank you, John. And our final question for you today, Dr. Mingle, is from June. And June asks, what do you think should be our highest priorities in the fourth quarter of each year to optimize our MIPS scores?
Great question, June. Let's walk through the performance categories one by one to comment on them. First, promoting interoperability, or PI. By the fourth quarter, there's not much you can add to your promoting interoperability score. You're down to your last possible 90 days of time to generate a final score. And remember, the proposal for 2024 is to increase this to 180 days. Starting in 2024. You can still get credit for exchanging data, for e-prescribing, or for checking your local PDMP or prescription drug management program when prescribing controlled substances. But most measures will take some development and implementation time, which is sorely lacking in that fourth quarter of the year. Now, as for practice improvement activities, IA, again, you need 90 days of participation for half of your providers to score on this activity. The fourth quarter is a little late to get started on anything new, and it's kind of the last minute also to get your participation up to 50%. Now, as far as cost, with 3/4 of the performance year now in the past, new cost containment activities won't have a big effect on your current year scores. Finally, quality. Your biggest opportunity for improvement in the fourth quarter of the year lies in your quality scores. Like cost, 3/4 of your performance year is already passed, but there are still some important opportunities to optimize your scores. Many measures look for the most recent activity, like blood pressure, hemoglobin A1C, colon or breast cancer screening, immunizations. If you've been monitoring your quality scores right along, it's a good time to generate a list of your eligible patients who are not yet in the performance MET status. You should check charts to see that MET performance has been reflected in your scores. If it's not, it's a good time to correct your documentation so that MET performance is picked up by your measurement system. Related to that, it's a good time to supplement the training of your clinical staff so that future care is documented in a way that is captured by your measurement system. If you're doing eCQMs, correction of your documentation is the only way to improve your scores. But if you're doing MIPS CQMs through a registry or Medicare CQMs, correction of your documentation is not your only means of improving your score. Your registry may be able to accept a spreadsheet of abstracted patient data, that's manually abstracted patient data, to more accurately reflect your great care and improve your scores. One of the main benefits of MIPS and Medicare CQMs over eCQMs reporting is the ability to combine data sources, including both digital and manual collection techniques for more accurate blended quality submission. Your spreadsheet will need to include the pertinent patient identifiers, the date the observation was clinically generated, and the nature of the observation. You should be able to get a template for this from your registry, and we provide those for our clients. You want to have enough data in the spreadsheet to be able to go back to the chart and prove the measurement if you are audited. If your patient will be coming in for a visit, you can provide and document the performance met care before the end of the year. And don't forget that many measures can be met if the intervention is provided remotely or not face-to-face. Your staff can go through a list of your not met patients and by phone schedule the interventions that are required to bring them up to date. In review, fourth quarter of each performance year is a great time to improve your quality scores. Double check your quality scores, provide missing elements of performance met care in a visit or non-visit method, finding and correcting documentation errors, supplementing your registry submission with manually abstracted quality data. For the other three performance categories, that's PI, promoting interoperability, IA, improvement activities, and cost. Though you have limited opportunity to improve your scores, it's a great time in the fourth quarter of the year to be generating a wish list for next performance year improvements. Thanks, June.
Yeah, thank you, June, and thank you to John as well for your great questions. Thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, and thanks to June and John for the great questions. I want to be helpful. I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience, ask your questions. We can be smarter together.